robotics?
Yeah, so on the clinical side, I do quite a bit of surgery, and we've become involved with working with the biomedical engineers at Johns Hopkins in developing a unconventional platform for using robotic surgery. The difference is we feel that it's necessary for the surgeon to be in control, so it's a surgeon-initiated system where there's a robot that basically will smoothen the movements, but since the robot can be connected to a computer, the computer can provide information to help guide movements, it can control movements, it can also monitor the movements which are made. So things like what we call virtual fixtures can be placed in. Virtual fixtures will prevent the instrument from going into a danger zone. In addition, there can be image overlay so that you can add information to the surgeon which they don't have at present, which will help guide the surgeon in making maneuvers. And there are surgical instruments which we call smart instruments, which provide physiological information of the tissue that you're working on. So for instance, you can measure oxygen levels to know whether you're in an area of hypoxia or in an area of normal oxygenation. That's very relevant for some of our diabetic patients that have large areas where there's very poor circulation and low oxygen levels. We have instruments that can detect force, and that's important because all intraocular surgery is done below tactile sensation. So every removal of any type of scar tissue is done without feel. So as we learn surgery, we have to look at visual cues to figure out how hard we're pulling on tissue. What we can do with the force sensor, since it's so sensitive, it can actually measure the forces that are generated and provide feedback, which can prevent the surgeon from either pulling too hard, causing a complication, or to inform the surgeon that they need to provide more force in order to complete the task that's at hand.
You see this as the emerging standard of care for this type of surgery?
I'm not really sure at this point. Part of it is that there, I think, is some reluctance among the current surgical community. People feel that the surgery is pretty good. My personal feeling is that there's always a better way, and if one develops this different system, it could make surgery safer. I think it also has tremendous advantages in determining and enhancing the way we teach surgery. The current way is see one, do one. With surgical simulators out there, it's see one, simulate one, do one. But it's unclear whether those platforms actually work. With the robotic surgical system, it can provide feedback to the system. It can also quantify every movement. And if you can quantify every movement, you can dissect what is a good movement and what is a dangerous movement. You can develop a library of physiological information that will predict whether a certain maneuver is going to cause tissue injury or whether you're going to successfully complete the task. That information can be used to inform and teach a student or learning surgeon how to do things. So, for instance, if you look at force, we know that there can be 7 millinewtons of force generated that's going to cause a complication to the retina. If you're peeling a macular pucker or scar tissue on the surface of the retina, if you go beyond that force, you can cause injury to the retina. And so from a teaching standpoint, we have two types of learning surgeon. One who's too reluctant to pull hard, and if we provide them information that they're at 2 millinewtons and they need to be at 5, they will know that they need to pull harder. On the other hand, if someone starts and is too bold and starts at a level that's likely to induce injury, they hear that message, then they can sort of reduce the forces and learn in a quantifiable way how much they need to reduce what they're doing.
By way of comparison, give us an indication of how smooth this particular robotic approach is compared to physiological tremor.
So physiological tremor has been measured in the average ophthalmic surgeon. It's 100 microns in amplitude, and the tremor is reduced to 10 microns. What that would potentially enable a surgeon to do is to be able to cannulate a blood vessel in the retina. So currently the average blood vessel that you could cannulate is about 50 to 100 microns in diameter. If you have an amplitude of 100 microns in your tremor, it would be difficult to cannulate that. And more importantly, what we found in our studies that is once you can cannulate, it's difficult to hold it in. And if you're trying to inject a medicine, it's going to take a couple of minutes because the size bore is very, very small, so it takes a while to get enough medicine into the blood vessel. If you have a robot, the robot has a 10 micron amplitude, so it's much easier to place it in. We've also found that it's it stabilizes the insertion of the cannula into the blood vessel, so you can stabilize that long enough to get the medicine injected.
I think both of these are really remarkable innovations and features that we look forward to watching and following as you go forward. Thank you so much, Professor.
Thank you.
Appreciate it.
Thank you.